Ready?
All right. Maddie, I'm assuming we're live. Is that right?
Yes, we are live.
Awesome. All right. Well, quick thank you and welcome to everybody. Want to just express my gratitude for everybody dialing in today and to Casey and Rob, two gentlemen that I look up to and respect and excited to hear their points of view today. Today is the second of these think tanks, and we started with a discussion about community health plans and how the current market dynamics are affecting thinking around planning. Today moves a bit more into execution. And so we're going to talk to these two gentlemen about exactly how they're executing, given some uncertainty in the market. Before we get into the conversation, though, I do want to give both Casey and Rob a chance to introduce themselves. And so, Rob, why don't we start with you, and then we'll go over to Casey, and then we'll get into the conversation.
All right, thank you, Trey. And good afternoon, everyone. It's a pleasure to be here. Well, sort of. Trey, my good friend here, invites me to join a technology panel, my specialty area. I can summarize my knowledge right now. One is you can never have enough IT staff. You always hire them. And when there's a problem, my CIO used to tell me, we need to open up the pipes. So those are the two things that I know around technology today, Trey. So thank you. You owe me for this. Again, anyway, my name is Rob Robinson. I am the CEO with Alliance Health. We are a local management entity slash MCO serving in North Carolina. We are one of 4 LME MCOs. LME stands for local management entity. That's about serving people who are underinsured. MCO, of course, stands for managed care, and that's serving people with Medicaid. Our population includes people with severe mental health, substance use disorders, and people with intellectual and developmental disabilities. We went live as a Taylor plan this past July 1st. A Taylor plan is very similarly to a SNP or special needs plan under the Medicare, where we serve a specialized population and we're responsible for whole person care. So again, I talked about us being in North Carolina. We're one of 4. We serve the central part of the state, more the urban settings such as Raleigh, Durham, Fayetteville, and also we serve Charlotte, among a couple of other surrounding counties. So again, that's who Alliance is. We are a staff of 1,500 dedicated folks. Thank you.
Awesome. Thanks, Rob. Casey?
Oh, good afternoon and good morning, depending upon the time zone. And Trey, thank you and for the opportunity to participate today. And I'm excited to be on the panel with Rob. I'm the Chief Information Officer at Health New England, and we're a provider-owned health plan. And so, we focus primarily on Western Massachusetts. And again, we provide all 3 lines of business, right? Direct to consumer through ACA. We've got a Medicaid plan, right? And we've got groups that we support. And so, I think this is an exciting topic because we've really been at the forefront of trying to find the right balance of modernizing technology, really improving member experience, right? Navigating sort of the complex pressures that face regional plans today. And I'm really excited about today's discussion because I think oftentimes folks look at regional plans with a lot of limitations, right? And I think there's a lot of advantages that we have and the opportunity to highlight some of those and bring those to light and talk about our ability to do things differently, which is, I think, a great topic, Trey. So I'm excited about the conversation today.
Awesome. Thanks, Casey. And again, my name's Trey Sutton, and today I'm coming to this conversation by way of background in Medicaid. So I was CFO of Medicaid for a little bit, and then was CEO of one of the other LME MCOs that Rob mentioned. And today's conversation is not about SIFWell. Instead, it's about community health plans. And Casey began the conversation a little bit with around how do we leverage our strengths as community health plans to really compete in the broader market. In fact, I see John Boudet on the call, former team member at Fallon, and one of the things that John said to me recently was, people seem to think that all health plans right now are in the same ocean or in the same boat, and when in fact we're in different boats, but dealing with the weather conditions or the choppiness of these waters, and they're affecting us very differently. So I think that's a lot of what sets up this conversation is how are health plans in the community health plan space addressing some of those. So why don't we start with, and I know both of you operate in the Medicaid space, Casey, you're also in the ACA space. There's a lot of talk about ending of tax credits, downward pressure on federal financing. Tell us a little bit about the current environment, how your teams are doing, and what's on your head and heart, so to speak.
Yeah, I'm happy to kind of jump into this. I think we're all pretty familiar with some of these, right? We've got, quite a journey so far this year. So if you talk about, the proposed Medicaid cuts and work requirements, the one, the big beautiful bill, right? I mean, that includes billions in Medicaid cuts, work requirements, tighten eligibility, right? Reduce provider taxes, coverage restrictions. And so if enacted, when we look at it from a Massachusetts, right, you have the potential for an organization like ours to see reduced enrollment, right? Increased eligibility verification burden. We know that at the end of this year, the ACA marketplace subsidies are expiring. And so, that can, potentially have a significant loss in terms of ACA enrollment. And so how do you redistribute those risks into other markets? And an insurer like us, we've got to be prepared from a pricing and retention strategy amongst that uncertainty. We're all familiar with the prior auth reforms that are coming around the corner, right? So federal, state lawmakers, right? Reducing delays, simplified language, dashboard transparency. And so how do we comply with those? But I think not only how do we comply with those, how do we improve that member experience, right? And then, we all operate within the states. And so there's, for mass health, the state budgets, right? There's an increase in mass health funding driven by long-term care needs. There's, health safety net fund is projected to face some deficits, right? And so if you think about rising premiums, healthcare cost growth, right? Shifts in self-funded plans and pull risks, right? What do you do? And I think for us, the easiest way to describe this are really across, one, proactive modeling is essential, right? How do you take advantage of the data that we have? What do we need to do to forecast enrollment, revenues, subsidy scenarios, right? How do we anticipate that financial impact? I would say two, it's how do we go through sort of that operational agility, right? How do we prioritize the prior authorization modernization, the digital engagement, the affordability tools to differentiate us? And then being a community, right? To the topic of today, how do we take advantage of that stewardship so it remains central, right? How do we work collectively with local agencies and local businesses and create innovative partnerships? And I think that's maybe one of the opportunities collectively here is how do we collaborate with providers and PBMs and state agencies, but talk about smarter cost containment, risk sharing, but how do we innovate too? And I think that's really where we've been focused, right? It's been a very dynamic place so far this year.
Yeah. Yeah, and the notion of bringing folks together and figuring out how to braid funding and do at least as much with maybe less. That came up on our last call. Jeremiah Rigsby from Care Oregon was talking a lot about engagement with CBOs and others to think differently about how to forge or reforge relationships to bring the most resources to bear given the current environment. Rob, I mean, you all are kind of in the crosshairs, being mostly a Medicaid program. I know you get some state funding. Some of that hasn't yet trickled down to you, but I know it's on your mind. Can you talk a little bit about how what's happening at the federal level and even maybe at the state level you're thinking about?
Yeah, thanks, Trey. And Casey, that was well said. I think I would say ditto to a lot of what you talked about. To be honest, it's hard not to get out of the wait and see mode, right? It seems like every day something's changing. I understand the Trumpster is now put a deadline for the Senate to get a budget out by July 4th. And so some of the elements keep changing, but what I think is pretty clear is there will be changes to Medicaid, and they could be some very harmful changes to Medicaid and for people. So we're trying to pay attention to that. We pay a lot of attention also to what's happening at the local level. We are a government entity, and so we do follow the local politics. Of course, what the feds do does impact us, but because of our governmental status, our General Assembly can treat us a little bit differently. I always like to say the General Assembly, when they need money, uses our savings, is their own personal ATM machine. And so we're trying to pay attention to that. I think the good news coming out of our state is, given the population that we serve, those with the greatest needs, they're trying to really protect those people, right? Dramatic cuts to people with severe mental health, severe substance use, many of these folks looking for housing, many of these folks just getting on Medicaid and having a coverage. It would decimate and return us to a state of high homelessness, high incarceration. And so I think the state completely understands that. And so I appreciate them at least acknowledging at the department level that they don't want to do that. Medicaid work requirements is another big one, of course. It is in both the House and Senate budgets here locally. Another thing that we're following, this is unique to North Carolina, but we have what's called an innovations waiver. It's for people with intellectual and developmental disabilities. We currently have 17,000 people on the wait list. So we're trying to, every year, the General Assembly does try and make an effort to reduce that wait list. It looks like they're not going to do anything this year. And then we're following direct care workforce wages and the impact of not continuing the effort to try and support that. That's still a big issue in North Carolina. The main thing that comes out of the feds for us is if the House bill passes, about 255,000 people in North Carolina could lose their coverage.
Wow. Yeah, big impact. And Rob, I know, you're on a 630 fiscal. Casey, I'm not 100% sure if you guys run on a calendar, but here we are at 626, well into the year. Talk a little bit about how the year's been so far with the new administration coming in. What's on, how's that experience been, and how are you feeling about the balance of the year, guys?
Yeah, that's a good question, Trey. So for us, again, we went live as a Taylor plan. So we took on physical health and management of the pharmacy benefits. So this is essentially a new venture for us. We started July 1st. Many years of preparation went into this. I think for us, there's been a couple of things that have impacted. I think if we would have gone live and the rules were the same throughout this year, I think we would have been in really good position for year two. I think there's a couple of things that have impacted us. One is the hurricane that was Helene, that hit the western part of our state, certainly impacted all of us. I'm going to focus on the one that's really hitting us now, and that's mental health parity. CMS, of course, has been pushing for mental health parity. I'd really be interested if other plans are experiencing similar. Again, agree with the concepts of mental health parity. Mental health services should not be treated than physical health services, but there are some significant impact that have, again, impacted quality and our finances. The requirements of parity have been problematic in a couple areas, in particular around the removal of prior authorization and be required to have an open behavioral health network, right? The removal of PA and open network is spiking low value care that is very likely not to drive longer term member savings. The biggest issue for us is our behavioral health spend. Remember, we've been operating a behavioral health carve out for 12 years. We have always been under budget. With parity being put in place, we are grossly overspent on the behavioral health side. For example, we've seen a drastic increase in mobile crisis. For us, we built a crisis system where we'd had one mobile crisis, maybe two mobile crisis responded to the community. By opening the network, anybody could become a mobile crisis provider. And then those mobile crisis providers primarily serve their members, right? The members, it's another way to bill for their particular members. And what's disappointing with the massive increase in spend, we're not seeing any reduction in emergency department or hospital visits. So the second piece, and I'll stop, is around the quality piece. We've certainly seen diminished in quality. While access numbers are increasing, again, that can be a good thing. We've also seen a significant increase in fraud, waste, and abuse. Over the past couple months, we've added 46 new contracts, and 26 of those providers are already in our compliance program, and the referrals to our compliance program keep coming. And so they're not used to the new Medicaid world where there's more accountability and responsibility. And again, I think it also has an impact on our existing providers, right? If for those that know behavioral health space well, in order to be sustainable financially, you need volume. So now you spread out volume of patients across multiple providers, and we've been through this before. Our good providers struggle because they're not getting the volumes before to be sustainable. So Trey, I think that's been the big issue for us.
Yeah, that's a really good update on how the year's gone so far. And whenever you invest dollars into care, you want to see the outcomes. And it sounds like in one instance at least, that's not manifest. And so disappointing to hear. Casey, how's your year been so far?
I think it's been pretty volatile, right? And pretty fluid, not only around the things that we talked about around the proposed, Medicaid cuts and the big, beautiful bill and a variety of other things. There just continues to be a lot of financial margin pressure, right? So you've got, in many places, Medicaid, I'll call it Medicare Advantage underperformance, right? You've got RX prescription and, costs rising, right? You've got commercial line variability. And this is where, you see group churn, you see sort of forced reevaluation of product mixes, right? They're focused on cost containment. And again, there's some concern in general around Medicaid revenue volatility as we go forward. I think if you couple that, wearing a technology hat, we continue to deal with, legacy systems, right, that add complexity on how we respond. And that addresses, our gaps in around pulling data together and being able to do the right analytics. Certainly interoperability mandates that are around the corner and our need to be able to respond to that, not only to meet the mandate needs, but actually meet the objective behind it, right? How do you reduce that friction? How do you improve that member experience? And I think all of us in some form or fashion are facing some form of, workforce and retention strain associated with folks. And so how do you begin to manage through that and kind of make sure you've got the right cross-functional alignment, clarity of ownership on work, and position a team to be effective and successful? And then, I think, as all plans, there's always been a focus on risk sharing. And so how do you take advantage of that sort of with the dynamics of amongst sort of this, what I would call changing and rising cost of care? And so I think that's a big piece you've got to be able to manage through. So all of those create quite a bit of volatility, and it forces us as an organization to make sure that we continue to evaluate the investments that we make. And it requires us to ensure that those investments have a quick turn to value, right? Where national players can sort of optimize for scale and we have to optimize for fit, not only for our members and providers and our community needs, but also on what we need to do as an organization. And so, what's changing around us matters the most, and we've got to just look at it and respond appropriately. And I think, to maybe the point of this framework of a conversation, right? Our size and alignment, right, across technical, administrative, clinical teams gives us the ability to prepare together, right? We don't need big committees and big organizations and multi-layered governance structures to get to decisions, right? And I think when conditions are volatile, we also have our relationships and sort of the agility that we use to stay connected and respond. And so I think that's sort of what we've seen a lot more of this first half of 2025.
Yeah. Casey and Rob, I love that both of you are already touching on some of the strengths that a community health plan can lever in order to deliver on its mission. And I want to come back to that in a second and really drill in there. Maddie had posted a question to the group, and the question was fundamentally, if budgets were cut, what would you protect under all circumstances? So I'm going to put you two on the spot here a little bit and get your thoughts. But before I do, the things that came back, I would protect our technology staff and ask leadership to work with us to figure out how to enable automation. There was a vote for care management teams compliance, payment integrity being at the front of or at the top of the list for keeping. And then, Rob, this will warm your heart. HCBS Medicaid services was one of the other things highlighted. We'd love to get you all's take, if and when these federal cuts begin to trickle down, what are the things that are at the top of your list for continued investments?
I'll be happy.
Yeah.
Go ahead, Rob.
Okay. Thanks, Casey. Yeah, that's a great question. And we do talk about this. And I wish I had a real grand, sophisticated answer here, but I think a couple things that we would do is one is around crisis services, home and community-based services would be one that we would definitely want to bolster or at least maintain. I think keeping some low-cost services that have had an impact, such as Medicaid-assisted substance use treatment. We'd also find ways to expand certain services such as peer support that is well supervised. I think we would ramp up faster our desire to expand specialized primary care and behavioral health outpatient services. And what I mean by expand specialized primary care and outpatient, I think that would include some support such as care management, who can help some of these folks. That is our interest now. We're piloting a couple of those programs, but we would want to expand those quicker. And then, of course, last, some technology pieces around texting and telehealth. I was thinking about this as you asked it more on the service side. I think the person who said is a genius that they would save their technology staff would be at the top of my list too. Thank you.
That's good to hear, Rob. Casey, how about you?
I'm going to take a little more of a technical focus on this, right? The things, in my opinion, that we would make sure that we protect, I think there's just core capabilities, right? Claims, enrollment systems, business continuity, security, right? Because there's just heightened, cyber risk, and we need to make sure that we can respond from an incident point of view. I would say, and almost in this order, right? Data analytics that drive margin and compliance, right? Because we're non-for-profit, but no profit, no mission, right?
Yeah.
And so our our MLR analytics, our provider dashboards, I think those become critical to continue to focus and be effective, and maybe more effective as we go forward. Everybody has the same conversation, but it's digital tools that reduce administrative burden. And I think when we take a look at CMS 57 final rule, how do we begin to apply that? I would say take advantage of our roots, right? Community partnerships, engagement at a tech level with local brokers, community members, community organizations, right? How do we make that connection? And then I would say there's always, how do you take advantage of the collective set of ideas, right? Best ideas win. Right?
Yeah.
It's as simple as that. And so given the time to value focus that we all need to have in our organizations, how do we focus on some high return on investments, right? Some innovation pilots that really turn the dial for us quickly and prove it out, because everybody's looking at metrics, right? Show it to me, prove it to me, right? And I think those really become the areas that, where, given the hat that I wear, where I would prioritize.
Awesome. Yeah. Well, whoever's down in, you heard it here first on what a CIO and CEO are making a priority. Casey, you talked a little bit about the strengths of community health plans as a differentiator. Rob, you mentioned Hurricane Helene. As a North Carolinian, at least a part-timer, most timer in North Carolina, it was warming to see how the LME MCOs came together, how the CEOs of all of them talked about it, the collaboration. I know you and Sean Schreiber drove down to Asheville. I know, one of my former board members drove down with a bunch of work boots and really showed up. I think that's the type of commitment that you see from community health plans, but it doesn't stop there. And so would love for you all to share how you think about the strengths of your organization as community health plans as opposed to a large national. So, Rob, why don't we start with you?
Absolutely. And, we get this conversation a lot, what's the difference between, and we get it a little bit differently because we're also, we're community based, but we're government run, right? And so I think we're a little bit different than most government entities. We're a government entity, have government rules, but we're asked to compete and act like a private commercial health plan, which is really, I think, a unique situation. There's certainly differences between the two, but I really think the differences are shrinking, right? Given our contractual requirements are essentially the same. Again, we're supposed to act similarly in our community. The RFP bids are now requiring some of the things that we just took for granted. What we do are now the responsibility of commercial plans in a new bid. So in that respect, I think the gaps closing a little bit, right? Disadvantage, we still can't compete with larger commercial plans with money. And we're always striving to keep up with technology capabilities. But again, I think we're closing the gap there as well. I think the biggest differentiator for us, and the one that we hold a hat to, is the fact that is our local level involvement in our relationships that we've built with local government and community organizations. Like you, we have staff embedded in the communities. I spend a lot of time in all 7 of our communities, meeting with leaders, hearing what the issues are, problem solving. I think the greatest thing that comes out of the work we do around local leaders is they get involved, right? I think all of our counties have invested totals of tens of millions of dollars, right? In Wake, they've given us $32 million to serve people who are uninsured. And they trust us, right? This has built a long-term relationship. One of my county managers had talked about there was a commercial plan going after their county. And I said, well, what are you thinking? I said, well, they had a good show. But the one thing that I know is going to be different is, Rob, when I call you as the CEO, you will call me back, right? And they don't think that they will get the response from the leadership that they would from a large commercial health plan, which of course we understand, but that's where I think the difference is. So we've got to continue down that road. Again, it's our differentiator. However we grow and expand, and we've doubled in size recently, it's always about how can you put an infrastructure in place that's going to support those local providers. And the last thing I'd say, we also recognize we need them, right? We need the counties for crisis services and for programs. We need have relationships with DSS. Our folks are all on Medicaid. We have great relationships with the housing authorities. Our folks need housing. They wouldn't get it otherwise. So those relationships are critically important to making sure our members get the care they need. Because if we're just out there offering them an outpatient program and that's it, they're not going to be doing well. So hope that answers, Trey.
No, that's great, Rob. Yeah. Casey, tell us about the strengths of a community health plan in your mind.
Yeah, I mean, I think Rob hit some really great points. And what I loved about it is we're all accessible as leaders. So he talked about, getting phone calls from local community folks, right? And being that connected. That is, in my opinion, a differentiator because scale isn't everything, right? It's insight and responsiveness that's really a differentiator. And so by understanding our members, our capacity, our ability to match services to the actual need, and being able to do that and start up operations with, a person or two to respond is just a quick way. One of our one of my peers, she kind of uses the term MacGyver, right? We feel like we're MacGyver-like. And the way I internalize that is we're creative, right? Because the speed of decision making and governance allows us to move quickly, right? The local ties really give us the opportunity to connect and leverage communities and really have a good understanding of what's in place, right? And the ability to have a smart team that is creative, right, gives us a chance to differentiate. And by doing so, and if you do so, and if you've been in play for a while, there's a community trust that you have. That's an advantage. And I think our responsibility is to make sure that, given that we're embedded in the region, right, and we'd answer directly, is how do we continue to manage and retain that trust? Because otherwise, it becomes some big ship that's passing, that's based out of, some other state with support in other countries, right? And that's what's different about us, and I think it's a unique advantage.
Yeah. It's really good, Casey. And the audience is coming back with local understanding as the key differentiator. I would offer it up if there's a specific example that somebody that's listening in has, or Casey or Rob, you want to add anything as a crisp example of how you've leveraged that relationship, I'd welcome that certainly. One of the things that we like to do in these sessions is make it as practical as possible. And, again, I'll use Jeremiah as the example. And one of the things he talked about was a committee bringing the CBOs to figure out how to braid funding together. Things like that are always helpful, but don't feel like you have to weigh in there.
Trey, I don't mind. I would love to hear from the audience, so I don't want to take away from that time. But
Yeah.
I think I do have a good example, right? When we
Love to
started
hear.
this
Yeah.
business, we served Wake County was our big benefactor. They were the county that we were the biggest county we had that we were responsible for, and they talked about wanting to help. And so we went down the path of doing crisis services, right? They want to do facility-based crisis. They want to do some SUD inpatient, behavioral health urgent care. We started down that path. They invested millions to try and set that up. And we built enough trust with them that they gave that money to us to manage, which was unique at that time. And then as we've gone and we've built relationships in other counties, just all of our counties by the end of this year will have given money to us to invest in crisis care. And that's where we think the strength of the partnership is,
Yeah.
that is very unique, and we're proud. Now, I spend a lot of time dealing with counties. I've got to pay attention to them. Is the best way that I'll say that, but it's all worth it in the end because we've created some very cool projects that work for thousands of people.
Yeah. That's a great example, Rob. Casey, anything to add there, or should we move on? Looks like you're
I
coming
say
off
we
mute.
move on.
All right, got it. All right. And again, just a reminder to the audience, please jump in with questions. We like to keep this conversational. And again, the intention here is practicality and usability coming out of this conversation. Guys, moving on to the next area, I want to talk a little bit about technology. Rob, I promise we're not going to go deep here. But as it relates to the previous bit of conversation, community health plans, one of the things that's on the other side of the ledger, perhaps, is the ability to make massive investments that any large national for-profit might be able to make. Can you talk a little bit about how you're balancing the buy versus build? I mean, even not getting into the technology deeply, but when your teams come to you and say, hey, we want to build this thing, or hey, we want to buy this thing, what goes through your mind, and how are you developing kind of a mental evaluation framework for those types of decisions?
Me or Casey? Want me to
Well,
go?
let's start with you, Rob, since you're off mute already.
All
We're in
right.
a spot here,
Perfect. We'll
buddy.
start it off. All right. So the build versus buy concept. So I will tell you, when we were preparing for the Taylor plan and taking on a whole new line of business, my mentality is we're going to build it, right? I think it's important that we have control over our business. Outsourcing to vendors in our previous work is a hit or miss. And so I was always build first. I have shifted that thinking some, so I'll talk about that in a moment. But when we buy now, it's when partnerships offer proprietary insights and speed. And I use SIFWell, for example. My goal was wanted to expand our data analytics teams and build that internally. We knew that was going to take a while, so in the meantime, we use SIFWell. What they've proven for us is they could provide timely data analytics reporting and have an expertise that we currently don't have. So we're still planning to build out a team, but we found it's definitely worth the investment to hire somebody like SIFWell that can get us timely, accurate, hear what we're trying to accomplish, which has not always been the case, and then produce what we need. So when we build, when we think about building, it's when local customization is critical, right? So for example, our care management tool requires a lot of customization based on state requirements and based on what the business needs. So it doesn't make sense to outsource that to manage completely, right? The other one is our claim system. I was very clear, our CFO was very clear that we wanted to have our own claim system and not to outsource that, right? Again, same thing with the changes in state IT requirements. It was important to us to have the ability to own it and not rely on other entities when at times it feels like there's state changes every single day that also impact other parts of the business. And then the other part of that is I really wanted to own the data, right? That's our data. And so I wanted to make sure there were no excuses from external folks that I know there's plenty that could do a really good job, but our intent was to keep it.
Yeah. Casey, you got somebody coming in your office virtually or physically every day about a new thing. Would love to hear your thoughts on this as well.
There's way too many of those, Trey. I just get bombarded, and I don't know how they get my phone number. It's ridiculous. I think Rob is put sort of the major pillars out there that make a lot of sense. We buy, to a large degree. And the reasons for that, and here's the way I would structure it and sort of a framework. There's a number of things that are regulatory or compliance in nature. There's no reason for us to be able to maintain those kinds of things, right? And to be able to apply new rules. Those things take advantage of what the market has already built, right? There's a number of commodity-based workflow solutions, right, that are out there for organizations. There's the Salesforces of the world and other things. They're off the shelf. Take advantage of that. There's no reason to build things like that. There are things that are quick to market capabilities. And so, portals, front doors, there's customization that you can do around the fringe of that, right? But a lot of the core capability, why invest the dollars? And I think sometimes there's limited skills. So if you talk about things around AI, we can certainly set up guardrails and make sure that we're aligned from a compliance and a security point of view. But there's a whole variety of other things that you might want to take advantage of the marketplace. And then how do you differentiate with the information, the data that you have, right? I think where you can differentiate, right, is really around things that are custom and unique to your members, to your member experience that you want to be able to differentiate in your outreach to your members. I think that's a place you differentiate because you can take advantage of the information that you have. I think there's also an element of data that's also highly sensitive, right? And there's proprietary data, and you want to make sure that you've got the right logic and rules, and you kind of maintain that inside. And I think that's another space where you want to, sort of build it yourself, right, and apply the right models yourself. I think anything that requires tight integration, right? But for us, I think given the cost of build today, It's really around where you can innovate on the fringe or on the edge. That's where you want to focus, right?
Yeah.
Because that gives you a differentiated capability, whether it's being able to bring together information, SDOH and other factors more and create more insight earlier on to be able to drive that outreach differently, to be able to drive the engagement differently, to be able to drive the care differently, right? And us being a provider-owned payer, right, the opportunity to kind of take advantage of those care models differently. Again, another great opportunity for you to look at things that you can do that, again, differentiate yourself from the marketplace, and gives you an advantage to really achieving your mission and goals. So that's the way I think for us, it makes sense to approach. I think we've seen success in some of that.
Yeah. Yeah, I mean, what I'm hearing is that the things that give you strategic edge, differentiation are really critical. You got the data, and in case you talked a little bit about user or member experience, and so I think that's really helpful for folks to hear. We did get one specific question. I'm going to broaden it a little bit. One of the questions that came in from Scott Brannon was in related to seeing real ROI from wellness solutions. I'm going to broaden Scott's question a little bit. Is there an investment, and you can name the company or not, but is there an investment or a particular functional area that was tech enabled of some sort where you're like, wow, I'm really glad we pulled the trigger on that? And again, it doesn't have to be a company name, but something that where you've seen real upside from an investment and automation, team extension, something else.
Hey, Trey, that's a great question, and I did see Scott's question around that. So let me start with ROI for us. So we just started as a Taylor plan, right? Our ROI, what we're looking for now is a little bit different than what hopefully we're looking for in a couple of years, right? We work with individuals that have been underserved, received years of neglected care. They require more enhanced services. What we've seen is the majority of these folks haven't seen a doctor or primary care in years. So we're spending our time trying to get these folks connected. We expect very much for our costs to go up on the physical health side because now these folks are getting the care they need. And we, of course, given the conditions they have, we expect them to uncover some medical conditions that we're going to have to be responsible for. So we're thinking in terms of ROI, particularly on the finance side, that'll be a later goal for us as we get through and uncover what the needs of these folks are.
No. Casey, any real thoughts on real ROI and where you might see that being accrued from?
Yeah, I think we see some in operational spaces, right?
Sure.
Where you've got the opportunity to sort of do some OCR or RPA. Those things I think drive some significant value. We certainly see some in some automated routing, right? Prior auth routing and responses that we're able to do, and some solution sets that fall into that space, including some decision trees that are automated and give us some capability. And I think these things matter because they cut provider abrasion, right? They ensure that there's compliance there, right? On the operations side, right, it improves timeliness and accuracy, right? And so whenever we can not only pull out the manual components, but automate that with a high degree of confidence, that to us is important, and that's got real return, right? I think there's also, spaces around scaling for capturing and bringing data together for audit and CMS compliance and member experience that we've seen some level of automation that really, again, reduces a lot of the manual task-oriented burden from our staff so that they can focus on higher value things and take away sort of the manual nature of those things. And so those things we've seen return quickly, and they're not long to implement, which is fantastic. Because I think today nobody can afford the 15-month projects or 18-month projects, that there just isn't a tolerance for that, and the marketplace is shifting too quickly, and you got to be able to get to value.
Yeah. Yeah, on the topic of value or value evaluation, I guess, just want to read a couple of these back to the group. When we asked about value drivers, when vetting solution, some of the top things that came back is how willing is the vendor team willing to work together and support the company that they're working with. Quality, impact, longevity, member outcomes and improvements, real ROI. And then what are the things that can help work us more efficiently? So we've got an efficiency vote. And then the other thing that was mentioned is how digestible is the information for multiple levels so that everybody up and down the organization can understand exactly what the vendor's doing. So some thoughts back there. All right, we're going to move on. This is kind of section 4 of 5 here. And it's about using tech to do what you already do, but maybe better. So, Casey, any thoughts about how technology is enabling your team right now? I know that, you mentioned AI. I mean, it feels like every day there's a new tool for quality assurance around software development or Cursor or anything like that. And then, Rob, I'm going to move over to you, and I'm going to ask it more from an operator or management lens. What are the things that are either helping your team accelerate their work, or things that were frankly getting in the way and that you've taken out of the equation? So, but Casey, from a technology perspective, what are you seeing that's really accelerating the team?
I mean, I think, there's been a lot of conversation around AI, right? And so we're not chasing AI for the sake of AI, right? We're investing where technology advances our mission, drives value, right? Strengthens really our operational capacity, and so, the places we're looking at are, automating anything that's high volume, low complexity tasks, right? Claims pre-editing and counter corrections, right? Any place that really provides analytics or member support or provider relations that, again, provides a level of workforce augmentation, where we can, close care gaps, right? Using data and using, AI/ML and to identify, high risk members, flag, SDOH needs, right? Enable the proactive outreach, regulatory readiness, right? Making sure that we accelerate where we need to, leveraging FHIR APIs, right? 57F consent management. And then, I would say there's what we're able to do is we're able to tailor our use of it, right? Because the one thing that I would argue we have, and maybe Rob has some similar kind of experiences. We've got a unique and a diverse population in our part of Massachusetts. And I just don't think national models, right, account for the local nuances. And so, how do we drive those things more effectively as we go forward, and kind of take advantage of the technology? And I would say we've put a lot of guardrails in place, and I apologize, I've got a dog barking in the background.
We all love dogs.
You know, technology's been around. Now, when I talk about technology, it's not the use of computers, right? If you think about the use of technology for centuries now, right? I think we've learned that technology can be used for good or for bad, right?
Yeah.
And we see some of that in the social world, and we see some of that with some of the AI automation and generation that's occurring. And if you go way back in time, right? I mean, even the first onset of technology, if you go back to the printing press, that was intended to be used to generate information that can be useful and propagated to large populations. And what it was initially used for is propagating lies and, creating witch hunts. And so, I think we've learned from that. And I think that's what's going to be so important for us as we take a look at AI, is to make sure that we've got the right governance in place. And we make sure that when we budget and allocate a portion of that spend so that we get to really position ourselves not only for success and compliance, but with confidence going forward that we haven't, used it to make any bad decisions or impacted a member in any negative way or a provider in a negative way.
Yeah, yeah. Casey, you talked a fair amount about the technology. Rob, I'd be curious to hear from you as well, from a technology perspective, or any other thing that you want to touch on that's made a big difference for your team.
Yeah, Trey. Even though you didn't ask me to say this, I do want to talk about the work with SIFWell because it's fresh for me. And I think there's a couple of things, right? We engaged you to work with us to address a couple of areas, right? Um, as of June 23rd, I think there's 2,000 emerging risk members by SIFWell are being engaged. When we talked to SIFWell, we knew who the highest cost, highest risk folks are, right? Our entire population is high cost, high risk. What we were looking for is who are those that are merging, that if we don't act now, they're going to become the highest of the highest risk. And so we can act now and not always be in crisis mode responding to that. So through your work, you've identified who those folks are, and there's a campaign now with our care management team to begin interacting with these folks, right? I mean, we've projected this might save us $200 PMPM over the next 6 months. That's a lot of money. Be awesome if that was the case. But those are fair, very fair based on what's been predicted. Very fair forecasts. The other thing you helped us with was our transition to community living program. I won't get into this DOJ settlement, but it's a program designed to move high risk folks out of long-term institutions and group homes into more independent settings, right?
Yep.
So we asked SIFWell, what's the biggest driver of the cost for these folks, or why they're separating from housing, right? One of our goals with the state is you got to keep these folks in housing. So they provided an analysis that actually unmanaged diabetes and not their mental health disorder, schizophrenia, was the top driver of separation for housing, which we did not catch in our work with these folks, right? So that was huge for us. We've redesigned our care teams. We now have nurses going out that will help with housing stability and transition success. Lastly, was around zip code. We've all done zip code work, but I think the level of analytics that they did really lasered in that we needed to launch some type of program, and we did. An eviction prevention team, and informed target investments in safer, better connected communities. So that was huge. And then the last thing was around health equity. That was a top priority for us, top priority for me, and they delivered a report to align with NCQA standards and fully mandated quarterly reporting to our executive team. So that was extremely helpful too. So that's an example of something that's made a big difference. And again, it continues to reshape my thinking about build versus buy, and that there are organizations and companies that can be quicker, that have the talent and expertise and the specialization to produce for us. So thank you.
Yeah, Rob, I really appreciate you saying all that. You're gonna make me blush, and then I know I've got some team members on, and so I'm sure it's welcome to hear. Yeah, we on the TCL one, we did get a chance to present with Ann Oshel recently, and that was a pretty cool thing that we were able to work on together. So I appreciate that. We're coming up on the top of the hour. These are intended to be a series of conversations with community health plans about the turbulent waters, how folks are maintaining delivery on the mission despite some of the challenges. Would love to hear where you two think this conversation should go next, or any parting thoughts for the folks dialing today. So, Casey, I'll give Rob a breath. Casey, do you want to kick us off, and where would you take this conversation next? And then we'll go over to you, Rob.
I think next, what we're going to be talking about is, and you see it in the marketplace with tech and with AI, right? Stakeholders want to see hard metrics, right? It's a prove it phase of automation, right? And demonstrate that tech bets are paying off. And I think I think that's going to be an area of focus, right? I think certainly CMS 57 interoperability readiness is on everybody's mind. I think we're also going to face 2026 budget trade-offs and scenarios. And I think that'll be interesting to understand how folks are sort of playing that off. You teed that up at the beginning of the conversation. For an organization like ours, there's going to be a lot of focus on member and broker retention strategies and what do we need to do and what are we doing, right?
Mm.
Given the landscape changes, how do we retain and how do we manage that risk as people leave, the ACA and shift around? And I think in anything like this, you've also got to focus on the talent side of it. So how do you reposition your teams to be able to focus on it, on the things that are most important as we go forward? And I think, it's a continued conversation on digital tools, right? Focus on reducing admin cost, right? Member abrasion, right? It's a continued focus on systems and protecting our systems and data. With the same things I think I've mentioned before: risk adjustment, RX trends. It's staying compliant, and we're going to have to go through. I think we're all expecting it. We're going to have to go through some honest trade-offs.
Yeah.
Right.
Yeah.
And then you got to do that, but you can't do that absent of taking advantage of innovation in the market, because you're going to need that to as a smaller organization and a regional plan, you need to take advantage of that and put yourself in a really strong place so that you can take advantage of all the pieces we talked about that make sense and give us value as a community health plan, right? From community trust to scale, to innovation, to partnering, et cetera. So
Yeah.
I
Casey, I
think
love
there's
that theme
focus.
of trade-offs. And maybe that's exactly what we're going to pull forward here is the notion of trade-offs as we move this conversation forward. Rob, thoughts as we wrap up the session today about
Yeah,
where to take it
I'll be
next?
quick.
Yeah.
Yeah, about future discussions. I'd love to at some point really hear from not me, from others about the real ROI of AI, right? In other predictive models. I'd be interested to see if it is working to the degree that we expect it to work, right? I think another thing, probably a little weedy, is building out better governance frameworks to protect equity, privacy, and then the local control. How does that work?
Yep.
While you're on ROI, Trey, if you could do a presentation on the effects on health for Ozempic and Wegovy, I'd be grateful. We pay a ton of money for that. And I
Yeah.
want to know if people get better, right? Like that's a key thing for the long term, for the long term. And then, of course, anything around workforce readiness and retention, we struggle at times with workforce readiness to step up for big projects. So those are
Yeah.
my hits.
Awesome. Thank you for that, Rob. And again, thank you both. You guys are both folks that I admire, respect, and being able to get the chance to interact with you too and hear a little bit of your perspective today. Super grateful. Huge shout out. I know we had Fallon, we had Health New England, Alliance, Pacific Source, Element. We had a lot of folks on today's call. So just shout out to some of the organizations I did see. Thanks for joining and thanks for tuning in. And I look forward to reconvening this conversation again with some other managed care executives in the community health plan space soon. Thank you very much, everybody.
Thanks all.
Hey,
Take
thank
care.
you. Thanks.